Hey everyone, welcome back to all my listeners. This is episode 10 in season 15. Today is Wednesday, July 9th, 2025. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. All right, you guys, I just wanted to start the episode off by just sending my prayers, my well wishes, my positive thoughts out there to those folks in Central Texas that lost many, many lives, young lives, in fact, over at Camp Mystic and the surrounding campgrounds in the region of Central Texas where that flash flooding happened the day after the 4th of July. So really, really sad, tragic news. I know lots of folks in the state of Texas. I lived there for just about a decade. So, my heart goes out there. I was telling my son, he, of course, grew up in the state of Texas. So, we have a lot of love and light that's being sent out. And I know that a lot of people are still trying to find those that are out there, those that are still missing. And it just breaks my heart. So I just wanted to start the podcast off with that. And I'm sure the rest of you had a great 4th of July, but I really wanted to just focus on that and just send my well wishes out because I still can't stop thinking about it. I'm completely sad that would happen to so many of our youth. You don't understand God's plan all of the time, but hey, this is what was planned for all of those young kids at those girls' camps located out in Central Texas. So God bless to everybody. All right, you guys. Anyway, let's get started on today's episode. So you guys know, my loyal listeners, this is the second Wednesday of the month, and I'm going to be focusing it on my Newsworthy feature for the OIG Work Plan updates for the month of June 2025. And in my Trusty tip, I wanted to go ahead and focus on 2 drug modifiers that are still an issue. And of course, I'm going to go ahead and close out and round out today's episode with a remarkable quote on hopes and aspirations by Norman Vincent Peale. All right, you guys, let's get into it. So in today's Newsworthy, the month of June's OIG Work Plan updates. There are 8 updates to the OIG Work Plan for the month of June 2025. The first OIG Work Plan update is titled Monitoring Nursing Homes Engagement of Medical Directors. Now, this report will be coming from the Office of Evaluation and Inspections. Medical directors at nursing homes are responsible for implementing resident care policies, coordinating medical care, and participating in quality assessment and assurance activities. Nursing homes are required to report hours worked by medical directors to CMS's payroll-based journal, also for short, the PBJ. The reported hours have raised concerns about nursing homes' employment and engagement of medical directors. There may be limitations to the accuracy and utility of PBJ data on medical director hours. So in the OIG's evaluation, they will assess 3 things. Number 1, the extent to which medical directors performed their required duties in nursing homes. Number 2, the extent to which PBJ data on the medical director hours are accurate and useful for oversight. And number 3, opportunities to improve oversight and transparency of nursing homes engagement and funding of medical directors through existing data or other monitoring mechanisms. Now, this final report is expected in fiscal year 2026. Now, the second OIG Work Plan update for the month of June 2025 is titled Medicare Advantage, Questionable Use of Health Risk Assessments Among Dual Eligible Special Needs Plans. Now, this report will be coming from the Office of Evaluation and Inspections. In Medicare Advantage, or MA, Dual Eligible Special Needs Plans, or DSNPs, they're designed to better manage and coordinate care for high-need patients who are dually eligible for both Medicare and Medicaid. For most health conditions, DSNPs receive potentially higher MA payments than most other types of plans to care for their high-need patients. In addition, DSNPs must fulfill certain care coordination requirements that do not apply to non-SNP MA plans, including the requirement to maintain procedures for care coordination activities following enrollee health risk assessments, or HRAs. Now, despite these higher payments and additional requirements, the OIG and other researchers have raised concerns about MA plans' use of HRAs to generate payments without also coordinating follow-up care, as required for all DSNPs. So this evaluation will determine the extent to which DSNPs received 2025 risk-adjusted payments for diagnosis reported only on HRAs or added to HRAs by chart reviews and no other records of service in the MA or Medicaid data. The OIG will also assess the extent to which select plans complied with certain care coordination requirements. Now, this final report is expected in fiscal year 2027. Now, the third OIG Work Plan update made for the month of June 2025 is titled Medicare Payments for Parenteral Nutrition. Now, this report will be coming from the Office of Audit Services. Parenteral nutrition is a form of intravenous feeding that delivers nutrients directly into a vein. Medicare Part B covers the reasonable and medically necessary costs of durable medical equipment, prosthetics, orthotics, and supplies, which include parenteral nutrition. And this is pursuant to the Social Security Acts in Sections 1861S8 as well as Section 1862A1A. Now, for the calendar years 2022 and 2023, Medicare paid more than $487 million for parenteral nutrition. For both years, CMS's comprehensive error rate testing reports, those CERT reports that I've talked about for years on the podcast, they identified improper payments due to a lack of documentation showing medical necessity, coding errors, and insufficient or no documentation. The OIG will determine whether Medicare paid suppliers of durable medical equipment, prosthetics, orthotics, and supplies for parenteral nutrition in accordance with Medicare requirements. Now, this final report is expected in fiscal year 2026. Now, the fourth OIG Work Plan update made for the month of June 2025 is titled Patient Selection Criteria at Kidney Transplant Programs and Waitlist Outcomes. Now, this report is expected from the Office of Evaluation and Inspections. Transplant programs within a hospital that has a Medicare provider agreement must meet the Medicare Conditions of Participation, the COPs, for CMS to grant approval to provide transplant services. The COPs for transplant programs include a requirement that programs use written patient selection criteria to determine a patient's suitability for placement on the transplant waiting list. However, CMS does not define patient selection criteria, which raises questions about what they include, how they vary, and why patients fail to meet them. This particular study will provide information about transplant programs' patient selection criteria for adult kidney transplants and the reasons that patients are not added to the waitlist following an evaluation for transplant. Now, this final report is expected in fiscal year 2026. Now, the fifth OIG Work Plan update made for the month of June 2025 is titled Medicare Payments for Clinical Diagnostic Laboratory Tests in 2024. Now, this report is expected from the Office of Evaluation and Inspections. Medicare is the largest payer of clinical laboratory services in the United States. Medicare Part B covers most lab tests and pays 100% of allowable charges. The Protecting Access to Medicare Act of 2014, or PAMA, in publication L number 113-93, requires the Centers for Medicare and Medicaid Services to set payment rates for lab tests using current charges in the private healthcare market. Now, on January 1st of 2018, CMS began paying for lab tests under the new system mandated by PAMA. PAMA also requires the OIG to publicly release an annual analysis of the top 25 laboratory tests by expenditures. In accordance with PAMA, OIG will publicly release an analysis of the top 25 lab tests by expenditures for 2024. Now, this final report is expected in fiscal year 2026. The sixth OIG Work Plan update made for the month of June 2025 is titled Effects of Including Non-Covered Versions of Stelara Biosimilars in Part B Payment Amount Calculations. Now, this report is coming from the Office of Evaluation and Inspections. Under the Consolidated Appropriations Act of 2021, Congress required the OIG to periodically conduct studies to identify drugs for which non-covered self-administered versions are included in Medicare Part B payment amounts calculations, and to determine whether they should be excluded from Part B payment amount calculations. The FDA has recently approved 7 biosimilar drugs for Stelara, a high-cost prescription biologic drug approved to treat certain autoimmune diseases. The intravenous versions of these drugs are administered by a healthcare provider and are covered by Medicare Part B. Conversely, the subcutaneous versions are typically self-administered and not covered under Medicare Part B. The provider-administered intravenous versions for 5 of these biosimilars were each approved under the same application number as their self-administered subcutaneous versions. Now, under CMS policy, both versions will therefore be included when calculating each drug's Part B payment amount. OIG will determine the effect of including non-covered self-administered versions of Stelara biosimilar drugs in Part B payment amount calculations. This final report is expected in fiscal year 2025. Now, the 7th OIG Work Plan update made for the month of June 2025 is titled Manufacturer Responses to the Medicaid Drug Rebate Cap Removal. Now, this report is expected from the Office of Evaluation and Inspections. To obtain Medicaid coverage for their drugs, federal law requires, generally, pharmaceutical manufacturers to enter into rebate agreements with CMS and pay rebates to states and the federal government. Before 2024, a drug's rebate was capped at 100% of its average manufacturer price, meaning that a manufacturer could not owe more in rebates than it charged wholesalers and retail community pharmacies on average for the drug. The American Rescue Plan Act removed the rebate cap beginning on January 1st, 2024, and in response, manufacturers reacted in ways that could significantly impact cost and access. The OIG will conduct 2 studies exploring the number of drugs affected by the rebate cap removal, the range of manufacturer responses to its removal, and the effect these responses had on Medicaid, Medicare Part D, and enrollees of both programs. This final report is expected in fiscal year 2026. Now, the 8th and final OIG Work Plan update made in the month of June 2025 is titled NIH Service Contracts. Now, this report is expected from the Office of Evaluation and Inspections. The NIH is the largest biomedical research agency in the world and has historically spent several billion dollars each year on service contracts to support its operations. A service contract is a contract that directly engages the time and effort of a contractor whose primary purpose is to perform an identifiable task or tasks. Past audits and evaluations have found that federal contracts reviewed often do not have well-developed requirements for the work and are not monitored well for performance. This particular study will assess a sample of fiscal years 2023 and 2024 NIH performance-based service contracts to determine whether the services, deliverables, and metrics laid out in the statement of work are clear and measurable. This particular study will also assess whether gaps existed in the NIH performance monitoring for the sampled contracts. Now, this final report is expected in fiscal year 2026. And now it's time for my best practice tips in Trusty Tip. So let's talk about a couple of modifiers that I've been seeing in my auditing that are still at issue. And I don't think I've talked about this duo of drug modifiers throughout my podcast seasons. I researched my archives and I don't believe I've ever touched on it. So I wanted to hit them up today. So those two drug modifiers are the modifiers JW and JZ. Now, these are to be used when billing for drugs, mostly those J HCPCS codes, for those injectates, for those substances that are either intravenously used or they're injected sub-Q, just under the skin. It's going to depend on the drug and why you are using that drug, through intravenous infusions or sub-Q injection type of purposes. Now, many of the MACs have useful fact sheets, or the CMS has a 9-page FAQ, or there's, of course, the CMS Internet-Only Manual, Publication 100-04, Chapter 17, Section 40. So lots of places for you to be able to find trusted resources on this duo of modifiers. Now, the appropriate definition for the modifier JZ. This is a good reminder, pro tip for my audience. That definition is important when you're auditing documentation. By definition, it means zero drug has been wasted. So all of the drug has been used, no drug amount has been wasted. So CMS clarifies appropriate use. This is very helpful. Medicare requires the use of modifier JZ in certain situations. They give the example, number one, the drug or the biological administered is a single dose vial or package. So it's only to be used one time. It's a single dose vial or package. They also state that the provider did not discard any unit of service. So they did not waste any of the drug. Now, an inappropriate use, they also clarify when it's going to be inappropriate to append the modifier, JZ. Do not use it in the following circumstances. Number one, if the drug or biological provided is in a multi-dose vial or package, right? So if your documentation is stating there is a multi-dose vial or packaging, you should be wary and not append that modifier, JZ. They also give another circumstance for you to not use it. You discarded one or more units of service for a single dose vial or package. Let me say that again. You discarded one or more units of service for a single dose vial or package. Because again, this modifier means there is zero wastage, right? Now, they dive deeper and talk about details. This modifier is effective for services provided January 1st, 2023, and thereafter. So again, this is a relatively new modifier that was out there. And it was out there because there was a lot of shenanigans out there as auditors are looking at documentation, right? So they had to develop this new modifier. The modifier identifies you did not discard any dose in the single dose vial or package. CMS implemented this modifier due to low compliance, or my shenanigans, right? Due to low compliance and correct use of modifier JW to identify discarded drugs. I'm going to go over what that JW is in a second. Now, the Food and Drug Administration, the FDA, labeling identified drugs or biologicals in a single dose container. The label identifies the dosage. And that's something that I do again and again and again, dive deeper into the FDA research of labels, right? When I have to audit injections and infusions and things like that, I have to understand the documentation dosage and then do the math on the billed claim, right? So you have to understand those units are going to correlate with the dosage that's written in documentation. And you can only find out what the appropriate dosage is by diving deep into those FDA labels. So that's another pro tip here, another trusty tip I can throw in. Now, moving on, let's talk about the modifier JW. So by definition, that is for the drug amount discarded, not administered to any patient. So again, the modifier JW by definition is for the drug amount discarded, not administered to any patient. So again, that is going to be what is wasted, right? You discard that drug. It's not injected into another patient or any patient, right? It is discarded. Now, the CMS talks about its appropriate usage. Using a single dose container for a drug or biological and not administering the entire single dose container. So using a single dose container for a drug or biological and not administering the entire single dose container. So that would be appropriate. The inappropriate usage. Using a multi-dose vial or package. Number 2, using the remaining portion of a single-use vial or package on another patient. And number 3, when the actual dose of the drug administered is less than the billing units established by HCPCS description. Now, again, this particular modifier has been effective and in use since January 1st of 2017. So again, a few years before that JZ modifier, but again, that was developed because there was a lack of compliance in this one, in the modifier JW, which was developed in 2017. Now, Medicare requires providers to submit those discarded amounts using the modifier JW. So when that's the case, you append that. You also have to notate the amount of the discarded drug in the patient's medical record. Now, I've seen that information missing as well as I'm auditing, but a simple query to the provider, to the practice, because they often have that information located in a different place. It's most often recorded on paper and it hasn't quite been submitted into the EMR when it's time for me to go in and do my auditing. So you just have to ask your providers, your teams at your practices to help you find that information, right? Because you have to notate that in the medical record. Notate the amount of the discarded drug in the patient's medical record. Now, CMS here on this WPS fact sheet that I found, and again, like I said, the majority of the MACs have a particular fact sheet. You just have to find it on their websites. Now, WPS goes even further and they give us billing examples of how to use the JW modifier. So WPS gives an example. The single-use vial label shows 100 units of a drug. The provider gives 95 units to the patient. The provider discards 5 units. Submit the administered 95 units on one line of the claim. Submit the discarded 5 units on a separate line with modifier JW. Show the 5 units discarded in the patient's medical record. So Medicare can allow a separate payment for the discarded portion when documentation meets Medicare guidelines. So again, it's about that reimbursement, right? So they will pay for that discarded amount if, again, that coordinating documentation reflects the amount that you discarded. So again, both pieces go hand in hand, like I've stressed on the podcast for years. Now, the patient is responsible for any unmet deductible and or coinsurance for the discarded drug. So again, your patients need to know what they're responsible for as well. Now, WPS also goes over a billing example without the use of the JW modifier. A unit of service for a drug is 10 milligrams. The provider gives 7 milligrams to the patient. The provider discards 3 milligrams. 1 unit of service is 10 milligrams and the provider administered less than 1 unit, right? Because they only gave 7. Submit the drug on one line with 1 unit of service. Do not submit a separate line with 1 unit and modifier JW, because billing a separate line with modifier JW results in an overpayment since a unit of service is 10 milligrams. So really, really good, important details in this WPS fact sheet. Now, they also give us a little bit more additional info. CMS requests providers to schedule patients efficiently to prevent discarding drugs. If administering to multiple patients and you still have discarded drugs, you can split the discarded amount between patients. This will reduce patient liability. Before submitting charges with the JW modifier, verify, number 1, if the drug is a single-use vial or package. Number 2, you should be scheduling patients to prevent discarding drugs if possible. And number 3, splitting any discarded drug units of service between scheduled patients. And finally, I focus Season 15 Spark on hopes and aspirations. I want this 15th season Spark to be filled with our world's thought leaders, writers, artists, philosophers, everyone who inspires us with their insights on hopes and aspirations. So, in this week's inspiring quote in Spark is from Norman Vincent Peale. If you want things to be different, perhaps the answer is to become different yourself. So very true, right? I love this quote on hope. It really speaks to what you want, what you desire, what you hope for. If it really is to make change happen, to be free from the status quo, I think this quote speaks volumes. If you want things to be different, perhaps the answer is to become different yourself. I'm happy Norman Vincent Peale's spark still burns brightly and can inspire so very many. All right, you guys, that wraps up today's episode. Thank you guys so much for hanging out with me today, the second week of July. I hope you guys are enjoying the warm weather that is out there, at least for another month or so in my neck of the woods. I hope a little bit longer for some of you out there. But anyways, you guys, I hope you guys have some good, fun things in store for you for the rest of this month of July. I hope everything is going well your way. Next week, I'm going to be talking about another healthcare spotlight for the month of July, as well as more trusty tips that I want to share with you. So anyways, you guys, I hope you guys have a wonderful, wonderful rest of the week. Thank you so much for listening in on today's episode. And I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.